Yes, hello. I'm sorry that I was not able to join you physically. I'm at a equally important meeting in Rome. We are going to talk about anemia and blood donors, mainly caused by blood donation. But are you showing my slides? Good. Before we talk about anemia caused by blood donation, you should look at your first-time donors before they donate and know that for the female first-time donors, probably around 25% or more will already have low iron stores. The next slide, please. Next slide, please. I'm not sure about the donation limits in in your country, but most potential donors will have a hemoglobin concentration above the donation limit. Those below will mainly be women and older men. Iron deficiency is frequent in women, and hemoglobin and testosterone is connected, and testosterone will reduce with age for men. And also for some of your donors, the low hemoglobin will be caused by thalassemia or sickle cell genes. Next slide, please. The donors will lose iron with every blood donation with the hemoglobin in the red cells, and what they will lose is proportional to the donor's hemoglobin concentration. If you have a lower hemoglobin concentration of 12.55 grams per deciliter, the donor will lose around 215 milligrams, or if you have a very high hemoglobin, the donor will use as much as more than 300 milligrams. Next slide, please. A little bit about how hemoglobin and iron is dependent. Iron is a prerequisite for hemoglobin to be formed, and with sufficient iron, you will have your habitual hemoglobin concentration. The pictures, the large blood drop is your normal hemoglobin, and on the bottom, the iron from the moon is suggestive of your ferritin level. The next slide, please. So with an iron deficient diet or with frequent donation, iron is first secured from storage, and the ferritin will drop. And remember that some of your donors will not have much of an iron store. Next slide, please. So once the your iron store is empty, and if you have an iron deficient diet or continue to donate, it will mean a drop in hemoglobin. And this is how a frequent donor will look sooner or later. If the donor starts with a high ferritin, it will take longer, and with a low, of course, it will happen quite fast. With an increased iron intake, for instance, iron tablets, the hemoglobin concentration will first increase, and the next. And if you continue to take iron tablets or eat very iron-rich food, the ferritin will also increase. At the next will come some physiologically about how you will uptake iron. Iron uptake and storage. A normal diet will contain 1 to 2 milligrams iron per day, and iron is only taken up in the first part of the gut, in the duodenum, in the acidic environment. From the duodenum, and next slide. the iron will go via the plasma on transferrin. And next slide. It will be used to form red cells, and in blood donors, most of the iron will be used to form red cells. In senescent red cells, when they are broken down, the iron from them will be recycled, which is most of the iron. When you have surplus of iron, in the next slide. Next slide. And next slide. When you have surplus of iron, it will be stored in ferritin. In the center of this ferritin molecule, you can have around 4 to 4,500 iron molecules. Next slide, please. A little bit of the regeneration after donation. Next slide. If you have non-iron deficient donors, that is donors with enough high enough iron stores, the hemoglobin will be formed to the previous hemoglobin concentration level in around 1 month. And next slide. For the regeneration of the iron stores measured by ferritin, even after 3 months, the ferritins will be lower than before the first donation. So it goes without saying almost that when you donate blood 4 times a year, you will have reducing your iron stores. Next slide. In your country, of course, there will be donors who are heterozygous for thalassemia or sickle cell. It is quite prevalent in your country, depending on region, and you will have carriers of this. If possible, these people should not donate whole blood, but they might, however, donate platelets or plasma by apheresis. Next slide. Signs of iron deficiency can be mistaken with signs of heterozygous thalassemia. What they have in common is a low MCV with small red cells, low MCH with low hemoglobin content in the red cells, and low hemoglobin concentration, slight anemia. And with ferritin, you can differentiate. The test you need to do this is MCV, MCH, and ferritin. And if you have low hemoglobin and low MCV and MCH and low ferritin, it is likely that it is iron deficiency, but it may also be heterozygous hemoglobin disease, especially alpha thalassemia. If you have low hemoglobin and low MCV and MCV, but a ferritin of higher than 20, iron deficiency, it is unlikely caused by iron deficiency, and it's more likely that it is some form of heterozygous hemoglobin disease. It can, of course, also be inflammation. What blood donors often need to treat this anemia caused by iron deficiency is iron tablets, and I can recommend that you at your blood center have 2 different types, since they can be one or the other can be favored by the blood donors. Next slide. Iron uptake is very difficult to predict because many things affect it, but the main factor is a small hormone called hepcidin. When you take an iron tablet, for instance, the hepcidin will increase and your iron uptake will be next to impossible. So no iron tablets should be taken more than maximum once per day. Sometimes even once every second day is preferable. Next slide. At my blood center in Copenhagen, looking at hemoglobin and ferritin and also white cells and platelets, we found 4 donors with chronic lymphatic leukemia, 2 with myeloid leukemia, hairy cell leukemia, multiple myeloma, and 4 cancers and systemic lupus and vitamin 12 deficiency, but also even if it was in Copenhagen, Denmark, where we don't often see these things, we've had 40 donors who were heterozygous for thalassemias. Also, which is more prevalent in Denmark, we found a lot with hereditary hemochromatosis, and 5 with polycythemia vera, which is a disease where you have uncontrolled production of red cells. Last slide. Conclusions and recommendations. Blood donors lose iron with every donation. I think you should press enter again. Yes. And I recommend that you have an SOP based on hemoglobin and ferritin. Also that you consider to have graded iron supplementation restricted to only those that would benefit. This would increase compliance. But also in your country have a plan to deal with those with low hemoglobin not caused by iron deficiency. Next slide. Shukran. And we made it.